I don't know if he's still practicing.
Seems
One
like
of our,
things are moving
one of our
fast.
orthodontists or maybe maxillofacial.
Are you an
His name
inpatient?
is Dr.
No, I'm not inpatient.
What's his name?
So
Oh my God.
You know, tongue in
his
cheek
son
for all of his
and his
patients.
family
Sometimes
should
too often,
shut
people like, I
You
survived.
should come and
yeah, he is. Yeah. He's not here yet. So he's.
Yeah, I lost he came, Dr. Wang, from Dr. Fitness. Good to see you.
Fine, how are you?
Doing fine, thank you.
Thank you so much. I meant to give it to you.
Hey, does he need a mic or does he need this or no? Okay. Can you do a mic check? How about this? Sounds better? Okay. Okay, well, I have 7:30. Do you want to go ahead and get started? Okay. All right. So welcome, everybody. It's my pleasure and difficulty to introduce Dr. Sharad Jaitly. I'm covering for Dr. Wang today, and Dr. Wang probably did that on purpose. It's hard to encapsulate Dr. Jaitly in a summary statement. He's done so many things, but he comes to us by way of New York. He's been affiliated, and although he's retired, I would say use the term retirement loosely because he's been quite active. But he's had professorships at Mount Sinai Hospital and Albert Einstein Medical College for over 20 years. He's the president of the Human Elements Medical Inventions Corporation, medical director of the MAG/Capital Medical Group in New York, and a diplomat of the American Board of Internal Medicine, cardiovascular diseases, advanced cardiovascular ultrasound imaging, nuclear and radiological cardiovascular imaging. His numerous academic roles, too many to count. He's also been awarded one of the highest honors in India for some of his humanitarian and diplomatic work there with patient education material. And I know he's got a really passion for medical humanities and wellness within the trade of medicine as well. So it's my pleasure to introduce Dr. Sharad Jaitly.
Good morning, doctors. Good morning, colleagues. And it's an honor to be here at the Carilion. Am I saying the name right? The hospital clinic, the Roanoke Memorial Hospital, one of the highly motivated institutions that I have read about recently, as well as from what I've been told, where increasingly more students, residents, and fellows, I guess they are transpiring and aspiring to become great physicians in the United States and all over. I bring this, actually I should go back to the connection almost in 1973 when I was a class fellow of Dr. Vikas Chitnavis, and some of you already know him very, very well. And of course, he and we are from the class of 1873 and 1973. Could have been 150 years ago also, we'll still be here, right? Well, 1973, and so today, this year happens to be our 50th, and so it's a mini reunion, and I'm so happy and proud to be part of my many alumni union here as well, and thank you for really giving me this warm welcome here at Roanoke Memorial Hospital. I come with a subject which is heartwarming, heart-touching, and sometimes heartfelt. And, it takes a trait, a specific trait, as we are all scientists first and then doctors and physicians. I personally feel that I think we have that unique trait, whether it's present in our chromosomes, in some gene, that makes us so uniquely special in this environment. Of the highest possible professionalism that can exist on this planet Earth. I think you all should really feel extremely proud, not only the doctors, but the nurses, the techs, the EMS, the dietitians, the pharmacists, the therapists, and the pastoral care involved in healthcare, each one of them should really feel so proud to be serving and putting the other sufferers, other sufferings first before their own. So pat on your back and say, hey, today I go to work, and you're so thankful that you have that uniqueness in you that makes you such a special person today to really work as a physician, despite what's going on in the rest of the world. And we'll talk about that as we go along through the slides. May I actually turn the next slide here? This dates back, of course, how the nurses used to be by bedside and offer that level of humanity, where the pediatric ward is actually from a pediatric ward. The slide is borrowed from Johns Hopkins, where the nurses are actually literally helping out the mothers and the care providers and many the closest families, and getting so involved with in day-to-day care of that little child, that brings out the warmth, the humanity, as you see through this slide. And I think the picture is more than a million words. I should stop right on that slide. The good old-fashioned way, here's a cartoonist depiction as to how a medical student or a fellow in research would be actually presenting in maybe a project in chemistry or something, or biochemistry perhaps, and you see all this. Are there people online, as a matter of fact? Are they? Okay, I do not have their, or maybe perhaps later I will probably have some idea. And my pointer would work if this is the top of the pointer. I got it. Okay, but anyway, so we have, there'll be another pointer someplace. Here we go. Okay, here are the students who are actually sitting in the galleries, the good old-fashioned way. Here are the professors, and the gentleman here is actually presenting his project, and obviously not knowing where he would lead himself to and others to, and implying that this will be the way where he will find his niche someplace. Here's a borrowed slide from Johns Hopkins also. It happens to be in 1873 when Johns Hopkins actually passed away. So that's why I was recalling 1973 and 1873. I think I overread last night a little bit too much to prepare for this talk. But 150 years ago, when actually, and following that, where, today we have the Johns Hopkins, one of the largest institutions in the world, and it was in the United States when actually this was installed. So it turns out that still, obviously there are subsets of institutions which have evolved since, and many other institutions over generations, over decades. But how the surgeons used to be all gowned up in whites, and if you recall, and today, of course, you have those scrubs, and for obvious reasons. But everything used to be incinerated, everything used to be distilled, the syringes used to be distilled. I'm going back a little history here primarily, allow me for a couple of minutes, as to how medicine evolved in those years, per se, to the present times. I take the extra pride because I always like to dedicate my talk to my parents first, because of whom I'm here, and because of whom all of you are here. I dedicate my talk to my late son, who passed away 2 years ago from a long-standing illness. My wife, she's in the audience. My son should be joining here soon. Older son, he's a professor at Virginia Tech. So we are bereaved forever, and I personally feel that at this point, the life is not the same as it used to be. And when you are a physician and you're a father, it becomes a little more hard, and the words cannot express. The pain is severe, and but the legacy must go on. As they say, we are all players in the circus. And somebody's controlling, the ringmaster is controlling us. The show must go on, and that's how I personally feel. We all have to be involved in our lives to impart that message, very important message. This slide actually dates back to, it reminds me, so it's the parents, my son, my late son, and my teachers I I personally, who bestowed all the knowledge that I can perhaps contain within the walls of my skull to impart or share with you. Allow me if I'm overstepping anywhere. But this is our. Let's see here if I can get the. Okay, here we go. This is the main ambulatory entrance, and Vikas can relate that, how busy that institution is. And this is our dean's office. It was inaugurated in 1947, and I'm proud to say that it is still the largest campus in the entire country. No, in the entire Asia. So I'm very proud to say that Vikas and I, we are from that institute, and we share those values. And all of us, especially the interns and residents and fellows who are listening to us online or offline. And I personally feel that every single day you bestow your professors what you are today for, and where you're heading to, because there are only three things in life that you can really be responsible for yourself and pay respects to: the parents, the Almighty, and the teachers. And that's how I see it myself. That's how I've been. Very importantly, why are we talking about the human element? Well, here's a depiction of the periodic table we all are very familiar with, and we know now we are hitting 118th element on the periodic table. Some of us went to med school. When I was actually a pre-med school, I think there were only 106 or 105, if we recall, elements discovered at the time. I think there are 2 more elements that are going to be added very soon in Japan. I think they're working on it. So hopefully by the end of 23 or 24, 2023, 24, we should be hearing 2 more elements that may be added to the periodic table. However, the slide speaks of where does the human element belong. Not on the periodic table yet. It's everywhere except on the periodic table. So let's not forget where human element is. Now, what is human element? That brings us to a very important point. Historically, human species have been bestowed with such great feelings that we have that 4th or the 5th or the 6th dimension that I think the rest of the million species around, they lack. And that's why we are the supreme species primarily. We suffer from grief, we suffer from sorrow, we carry it on, we suffer, or we have laughter, we have great moments, we have the rest of the species you look around, they're happy creatures, they're all going by their business, not that they're not stressed. A deer is constantly looking out for the predator, and so a smaller fish is always looking out for from the big fish to attack. So these are they do have their own levels of stress. They have their own levels of understanding. But the fact is that human element, when you throw into the human species, that makes us so unique that we come out with that feeling, and that's why the word called humanity. Sometimes we are called human beings, but I like to say ourselves that I think we should be it should be called being human is better than human beings. Being human speaks of what humans do or what humans should be. So the definition of human element is it's a way of conveying the kindness, the respect, the dignity, the comfort through your voice, through your gestures, through your written statements, through your prescriptions, through your therapy, through your treatment plans, through your advice, through maybe a hug, maybe a kiss on the forehead of that terminally ill patient, perhaps, or even talking and speaking out to them and say, look, I've gone through those things, and myself, I fully understand what you're going through, and that makes flow of that human element for the other party or the other person to understand. It's not easy today, specifically so, because we are surrounded by the myriad of blue screens, and I'm a nuclear cardiologist, so, not to say that, hey, look, you guys are automatically, obviously, you're so involved with so many things that I was just looking at Dr. Sweet's, the sheet list from the sign-outs, and I can tell that there is a huge bunch of information that you have to really put all of that in together here before you can actually go and see a patient. So structurally, metabolically, and biochemically, you know the patient before you actually go inside. which is great, but nothing like going inside the room and having that interaction with the patient and the patient family. I always call it a patient and a family as a unit, I personally feel. You cannot you cannot segregate them. They have to be together. And many times and it's also important. We all have dealt with diabetics, hypertensives. We have all dealt with cancer patients. We all dealt with cardiac patients. And we always feel that actually it's easier to say, hey, look, go on a low cholesterol diet, start losing weight, quit smoking. Easier said than done, but how do you do that? That's the key. And that's where the human element is involved, because you really spend that extra 60 seconds into it and try and say, look, this is how you'd want to do that, because that's what makes the difference. So recognizing the problem, rationalizing, obviously, you certainly want to make sure that everything is nicely rational. You really need to have that rationalization of every single bit of therapy or treatment or prescription. My professors always used to say, and Vikas can recall that statement, it's easier to pick up a pen and write a prescription, but it's a lot difficult to put down the pen and not write a prescription. That also applies for the test that you're ordering, the imaging that you're ordering. Today we have access. All it takes is a click, click, and you have all these tests ordered for the patient. Done deal. And the patient is running around all over the town and getting all these tests done. Next thing you have is all that information. So ask yourself a question first before you order these tests. How's that information going to change my treatment plan, my diagnostic plan? And that is so important in today's life. So that's called rationalization. Try to imply the best way, the most cost-effective way, really, you can have those patients worked out. And of course, because your goal is really not that you're always a curator here. You're not always looking for curing the problem. That's a myth. Doctors in white coats, we always are considered as gods. I bow to God and say, look, I'm not. I'm just a human being, maybe with some extra medical knowledge to help patients who are suffering, who are knocking on the doors with pain and grief and pain and suffering. So my concern is always the following. I said, look, we can only help with what we have in the information that we have. And I cannot, but the fact is that how you approach that patient is so crucial. Why is there a decline? Now, why is there a decline over, I'm not used to this, but here we are, decline over the years of the human element? Well, partly in the past 2 years, we all recall. And again, with all due respects, I think the COVID pandemic really took us apart from each other. We were not sharing that humane touch, the humane connection, or the bridge, or the bond, as you may call it, in person all the time with us. What was happening was we were going farther away, and the advent of social platforms. Look at that, we are WhatsApping, and I was in Australia, and somebody was telling me that actually what we do is we put our imaging on the WhatsApp and actually send it out to all our residents and fellows. The next thing is by the evening, they all have all of that together. Of course, they have a very closed group, so nobody can really, but there was a time when actually we all used to sit down and have a multidisciplinary approach where you could sit down and speak to them. I'm from the old school, and some of us can relate that. I think I'm the oldest here. But some of us can relate to this finding here is that doctors always love to make rounds with a nurse, with a pharmacist, with a dietitian, and perhaps a therapist, and of course a technician, and then maybe a pastoral if he or she is available. And they because it makes it a lot easier because the interactions are happening at the time of the bedside rounds rather than in a meeting somewhere else. Because by the time you come back, half of it is already evaporated. I sort of feel that it may have to be reinvigorated, and we'll talk about how to reinvigorate that human element back in again, and that's the cue. So there is a decline. There's also a decline because of the third-party payer system that's involved, and so on and so forth. So we'll talk about that in a second. Let's move on to the next slide. So now people have commonly used these words: sympathy, empathy, and compassion, as you see. Is there a subtle difference between the three? There is. Sympathy is something where you actually know the person is suffering. Know that the person is suffering when he or she comes to your clinic, your office, or the ward presents. Empathy is something where you actually go the 9 yards further and say, look, I understand, I feel your suffering. And that makes a huge difference. Know the suffering and feel the suffering. And compassion when you apply, especially in a cancer patient or especially in a chronic illness, perhaps maybe neurological, ailment, or, it could be a mental illness, it could be a physical illness, a psychosomatic illness. And that compassion, when it comes in, you really are able to not only know the grief, feel the grief, but you are also wondering how best I can help you in that circumstance. And that's what makes it so unique. And that's where the human element, sort of needs to be revived or has to be brought back in. Having said that, obviously you want to try and, and because the doctor-patient relationship, I do want to say it's one of the most time-honored relationships nowhere else that exists in the world. A father and a son, and a mother and a daughter, and a husband and a wife may have a relationship, but many times you'll find the best friend to really discuss is a doctor. I've had patients in my 40 years where they actually came and only to talk to me because they said, Sharad, Dr. Jaitly, you're my friend. I want to talk to you about my sufferings. So there is that part of dignity, there's that part of sanctity, there's that part of sacredness when a patient shares with you. How many times have you picked up your phone and say, hey, by the way, the accountant calls you and say, by the way, hey, 15th of April is around the corner. You better put $30,000 in your write a check because that's what you owe from the previous. Boom, and you can't explain to him, hey, look, how do I bring that out, whatever that X amount is, before that date? When was the last time a lawyer picked up the phone and say, hey, by the way, I know you're suffering, but at the same time, this is what you have to do. There is no mention of that either. Not that I'm saying, hey, any of those professions are anyway inferior to us, but the human element is something extremely unique to medicine. When was the last time, or when was the time when you actually asked somebody and say, look, by the way, you have to put 50% down first, 25% by the time you finish the test, and another 25% before you actually leave the clinic. Never do that. We never do that. You know why? Because we are unique. We are absolutely. You call the roofer says. You call the plumber, they take the. So it makes us extremely, extremely unique species, and it has to be within your trade because that's what you've been bestowed here. Understand yourself that if you're sitting in the white coats, and especially the interns and residents that I see, the students, I personally feel that you should really feel extremely inspired that, hey, look, you are going to follow a journey where you've put in almost like 4 years into pre-med, 4 years into med school, 3 years of residency, and maybe perhaps another year, 2 years to get your boards out of the way. And then maybe if you decide to specialize, do another 3 years of fellowship, if you're lucky to get into pulmonary cardiology, otherwise 5 years of fellowship into neurosurgery and what have you. Some of the students are already nodding there. And half the life is over. And guess what? The prime life is over. Well, actually, you could be hanging out on the streets and doing other things better if you like to. No, you chose not to because you wanted to really actually pursue a career, a profession. And that's what made you so special. And, I don't say it's because of you. I think your parents, the culture actually made you grow into medicine, made you come into medicine. Maybe there was something heart-touching that happened to you in your life that made you a physician. It is an important profession. I do want to say that. So do not forget that. Okay, let's move on to the slide because for want of time, I really want to cover most as I can. Well, we've talked some of the things why human element is on the decline, as you've seen, and third-party payer system. Well, we've talked about that because that changed the managed care. I think about in late 80s or early 90s, where doctors were thrown into another turmoil. Now, obviously, the younger generation does not have that grasp at all, but I think Dr. Sweet and Dr. Shad, I think we can, because, and we are the contemporaries, I think we can quite relate to as to where the rules would change in the middle of the game. Let's put it this way. You're playing the soccer game and somebody say, hey, it's not going to be 90 minutes anymore, it's going to be 120 minutes. Or the goalposts have changed. I'm just giving an analogy. So the third party's peer system has changed a great deal where people have chosen chosen that as a human decline excuse, if you will, because you're far removed, and most of the times you're filling out the administrative papers. You're half the time you're doing the clerical work. The nurses and the staff are taking extra time to really justify for a test, for a visit, and what have you, et cetera, et cetera. So it is a huge what you may call where are we? Okay, sorry. So one of the things that I always say is that may be one of the things here. Let's move on to communication. Why is communication so important for us? Well, let's put it this way. It's easy to write a test and say, hey, I'm going by very simple. Say you ordered a CBC. Now, CBC is a blood test. Okay, it's a very simple test, costs pennies, or your analysis, whatever. But there should be a reason. Understand why you ordered that test. So communication to the patient is very important, especially when you're ordering some very fancy tests like which are on the around now, the MRIs, the PETs, and the SPECT scanning and what have you. Try to communicate and let them understand. Give them the opportunity to sit down and ask questions. And believe it or not, that actually irons out lots of problems, because you're not going to be awakened at 2 a.m. Hey, doctor, what was my result like? Or the next morning, somebody's waiting in the ICU and say, hey, how did the patient perform with the previous VQ scan that you sent him down for? You've answered that question most of the times. You say, hey, look, this was a test only to rule this out, or this was a test which was to confirm this, da. So the examples are huge that we can go on, but the communication is very important. Writing a prescription, I'll give you an example, an aspirin. Aspirin is the easiest thing you can write, right? And then you go next patient, next. No, but how many times to take, when to refill, how to take it, at what time to take, and so on and so forth. Should it be enteric coded? Well, all of that could be answered in what, 30 seconds? I just did. So when you advise a patient and say, I want to prescribe you penicillin, how many days to take it, how often to take it, are there any allergies, history of allergies, it takes only 60 seconds, my friends. But you know what? It is so important that we have established that human element into that communication each time whenever you speak to. So most of the time, I think another line from my professors at my med school, and again, I'm going back to 1973, where one of my professors told me that most of the time, 90% of the times, you'll be able to make a diagnosis of the patient when he or she arrives at your office just by listening to him or her. History alone. And even today in 2023, I say that's absolutely 100% correct. 10% of the times only you're ordering a test to support by means of trying to see if you can rule out your differential or narrow down the differential and be able to achieve that. Most of the time, if you listen to the patient, I think you'll be able to clinch down the history. How many times have I seen chest pains in the emergency room? Thousands and hundreds of thousands of times. How many times have you gone to the ER and seen chest pain? Are all chest pains alike? No. Do all chest pains need the same workup? No. But I think just listening to the story, and that'll tell you exactly how it goes. I'm picking chest pain, but you could be talking about abdominal pain, you can be talking about fever and headaches and what have you, and other breathlessness, etc. But I think the clinical history will tell you a great deal, and that's great for the interns and students, that you cannot cut you cannot cut the chase there. You have to really follow what the patient is telling you. Of course, if he or she starts talking about a cruise, and next thing is talking 15 minutes how good the Bahamas trips was, then you have to sort of steer the ship back on and say, hey, coming back to your chest pain story, lady, you want to tell me more about that? In this way, but that's where your art of medicine comes in. That's where, because you want to be very cost effective in making sure yet the patient stays on the track and you're able to, ascertain all the possible, information. Honor the privacy of the patient, extremely very important. Where else can you expect this? Because somebody's trusting you with your mental state, your physical state, and the social state, and even goes out and tells you about the family and affairs and whatever else is going on in somebody's, or maybe with the bosses and with the treatment and et cetera, et cetera. You'll be surprised. So that privacy is extremely, extremely very important. And of course, allow ample time to ask questions, or allowed to be asked questions. Now, we talk about this. The reason I threw this slide is primarily because I personally feel that everybody's worried about, oh my God, there are malpractices. Yes, that's a true reality. But you know what? If you practice good medicine, a standard medicine, from your zip code, nobody can ever touch you. There could be frivolous lawsuits, but it doesn't really matter. Don't be afraid of that, because it's so important that what you're practicing is a standard medicine. And that's what the court likes to see. But if you communicate and if you document, you're solidifying the two pillars. Remember, in the court of law, if you did not do an examination or did not document an examination, you did not do one. As simple as that. So documentation, even a verbal communication of whatever nature, I think needs to be documented. It's very important for the interns and residents too, and I'm sure Dr. Sweet would agree. It's so important that in day-to-day life, as you go with your care that you offer, you'll be, and plus, you know what? It'll also serve you as a great deal of reminder, because 6 days from now, sometimes even 6 hours from now, you may not remember exactly what you discussed with the patient. Am I right? Because you've seen 20 other patients in between. By then, it'll be all gone through the air. So it's very, very important we document, we communicate, and of course, all of that in a highly private, in a fullest privacy, not in the hallway, not in the stairwells, and not in the elevators. Those days are gone, and certainly now we have to do it only in the sit down meeting, perhaps maybe with a patient or the family together in a patient room. Well. First, do no harm. The reason I bring that up is very important, because whatever you do, make sure there is no harm done to the patient. That's your hypocritical. However, the Hippocratic oath is normally taken at the time when actually you're graduating. I personally, I'm of the opinion, I think it should be in the very early stages of your curriculum, maybe the first few days. The day you wore a white coat, folks, the day you wore your white coats, I think the oath should be taken. And some of you may agree on that. I think most of you would agree on that, because those are your formative stages, formative ages in those 5 years of your schooling that you are actually developing that first do no harm. Why do you have to wait till you graduate and actually take an oath then? I personally feel that way, and I'll show you exactly why. This was a small article that came out actually in one of the largest circulations in India about my human element, and it has been shown to improve the clinical outcomes. I hope you all agree that clinical outcomes will only improve if you have. In fact, somebody said that you're only half good in your craft if you do not have the human element. You know, you throw in the human element, then you're a total physician. So that's one of the things that you have to recall. Incidentally, I've written a book on this, as a matter of fact, and I have some books displayed out there if anybody is interested in. I took the permission of Dr. Yang and Peggy, and they suggested that, hey, look, since you're an author, you might as well bring in some books, and somebody's interested, you can sign in and they can purchase one. And we're offering it through a link, and I'll show you exactly what it is. This was at an interview conducted on ITV, which is the Southeast largest Asia TV. I was invited to talk about on human element. And some of the things that commonly strike to you is when you and I have seen difficult patients. I should throw in another D there. That's difficult. But I think denial, defiance, and disappointment. Those are the three we are looking at. And what do we understand when we say a patient is in the denial, defiance? Well, you know, that's another illness. As if the myriad of symptomatology the patient came in with is not enough to really sort of, for you to devour all that information, sort of teeter it out and come up with a nice diagnosis or a cure. But now the patient is not. A simple thing like, hey, look, I gave you an aspirin, but you're not taking it. Hey, I gave you this test, a mammogram to go to, but you haven't done that. Hey, I told you to go and get a pap smear. You haven't done that. Yeah, I told you to get a colonoscopy as a routine because you have a family history of certain things going on, or polyps or what have you. You haven't done that. So defiance, the denial, the disappointments, and all those things, they can come in, and you have to start, again, all of that needs to be taken care of at one point of time and sit down, and you have to go very thoroughly. Because you know what? There are times when you have to end up using scare tactics. It's okay to use scare tactics. Hey, I'm sitting on the beach and somebody says, by the way, the whales have been sighted on the Jones Beach, New York. What do? You pack your bags and leave. Put it back into your station wagon and you're out of there, right? You don't want to be anywhere close to the water. Similarly, those are scare tactics in life you're always used to. Hey, the weatherman says, the weather doesn't look good, 48 hours later, there'll be a blizzard. What do? Either you leave the place or you get out early or you stay put in a safe environment, in a warm environment, and go out and pick up all your batteries or whatever else you need to make sure that you don't lose power. So similarly, the scare tactics to be used in medicine are absolutely legit. A smoker comes in and you're advising, quit smoking. Oh yeah, what a great statement you made. It's written on that pack, statutory warning by the Surgeon General, injurious to health. Need more to be said. It's there. You didn't do anything extra. But how to quit smoking, you sit down and talk to that patient. And that is so important. How to quit drinking, you sit down and talk to that patient. That counseling, the what you may call a great deal of social understanding as to what led him or her into that habit. It is so crucial. Hey, look at it this way. It's so important for us, all of us, to really look at that broken arm and a broken leg, and we have the same respects, don't we? We have the same respects on that illness. But if somebody comes in with, say, is overdose, drug dependence, alcohol dependence, etc., what happens to our compassion then? Is there no compassion? It's the same person, for no fault of his, for no fault of hers, has or is succumbing to that disease, to that illness. So, and we all attach that stigmata, unfortunately, to that mental illness, and we don't talk about it, we shy about it. And I'm sure my physician colleagues here would agree. It is so important for us to immediately intervene, get the intervention done through a psychiatrist, call it a liaison immediately, and start working on that. How far will they be helpful? But I think that is something which needs to be analyzed and assessed with. So it is so important that it's not to be forgotten at any time, because you're a physician. You're the gatekeepers. You're the gatekeepers. You are actually calling the shots. You're calling the specialists in action and have them come in. So it's extremely important for those moments to really be recognized and be able to offer that in a very, very compassionate way. Remember, very, very compassionate way. Because compassion, like I said, you have to be able to feel, you have to be able to understand, and still be able to find a solution. And that's compassion. Now, we all know sympathy, empathy, and compassion. Very important. This is my, I spent about 25 years at Calvary Hospital, which is, I think some of you already know, it's the only hospital of its kind in the world, which takes care of the acute care, terminal care. And my wife, she's in the audience, she's an oncology hematologist, she's also part of the Calvary team. And so as a matter of fact, we have really devoted a lot of time. Of course, I was an attending physician and a consultant. She has been a palliative care director there. And turns out that palliative care is now being recognized increasingly all over the world. I just got back from Australia. Prior to that, 2 years ago, I was in India, and I think palliative care institutes are being set up there now. But we have had this focus. I think the longest lasting experience that we have had has been at Calvary for now. And so I take the pride in really bringing you that information. I personally feel that there is a humanity involved, because I think when you look at a dying terminal cancer patient, see, everybody can offer chemotherapy, everybody can offer radiotherapy, but think of a person who comes to palliative care, wherever, in whatever institute you're in, and the person is extremely in pain. The first thing you do is you develop a pain regimen. You try to assess and try to understand whether the patient goes on a morphine drip or a Dilaudid drip or whatever else, and try to, in the first few hours, get the pain. Pain is the worst suffering anybody can have, besides many others, breathlessness, and of course, the swelling and anorexia and nausea and vomiting that comes in with the territory there. But pain is the worst suffering. You've got to get the patient pain-free. And I tell you one thing, at that institution, I personally felt that there's not a single patient. Some of us can relate it because we have had family members or friends who have died of cancer or have had cancer. So we can all relate that. We've seen grandpa, granddad, grandmom, uncle and aunt, mom and dad, whatever. So at this point, really, we feel that could have been one of the things that we can relate to. So the illness is such that we always feel that there needs to be a pain relief immediately offered. Nutritional support need to be offered. Infection control and sane and meticulous other hygienic care needs to be offered. All of much has to do with palliation. Why? Because you're not trying to cure the patient. They may be coming from Memorial Sloan Kettering or MD Anderson. But you know what? They have thrown up their hands and at this point say, look, we have no radiations to offer. We have no chemotherapies to do. Take the patient home. As simple as that. That's how they say. But you know what happens? We, the palliative physicians, extend and embrace the patient and say, we can still treat you. We can treat your symptoms. What's wrong? And guess what? The same person, the same lady who is now 6 hours into that morphine drip is pain-free. You go back into the room, she's smiling and watching TV. Says, hi, doc, how are you? Yeah, and then I walk in and say, hey, I'm supposed to be asking you, Jane, how are you feeling? Oh, I don't know, I'm feeling pain-free now. That's terrific. Next thing comes on the schedule is, he or she wants to go and do some crafts. He or she wants to do something called arts class and bring out the skills. Some of them want to go out into sit on the patio. There might be a band playing for them, and they start tapping. And when you see that person tapping on the knee like this with the rhythm, or tapping with the toes on the floor, you say to yourself, you're a winner. You know why? But that patient has forgotten one thing called pain, the grief, that suffering. For a moment, she was lost. I've not had a single patient in palliative care, I should say, who has ever told me, because if that was the question I asked, what do you expect us to do? You know the answer was? Not to keep me alive. That wasn't the answer. The answer was, keep me comfortable. Doctor, keep me comfortable. They're not afraid of dying. We are afraid of dying. When we live, we are constantly afraid of dying. We step outside, you gotta be watching the ladder, watching the steps as you come along, watching other things. We are afraid of dying and hurting ourselves. A dying patient is never afraid of dying. He or she just wants to be comfortable. You know that's coming. So anyways, the evening comes around, and the next thing is the dinner is being served. There's lobster tails she ordered. She ordered a beer. At this point, let her have a beer with the lobster tails and mashed potatoes and beans, etc. Howsoever small little speck she'll have. And that brings out a smile. Now the family walks in the same scene and says, Doctor, I can't believe, is that my mom? How great you feel. It's priceless. It's priceless. Because that's when you'll feel, it's not the remuneration you're collecting at the end of the day. What you're collecting is the accolades of gratitude and the feeling of thankfulness coming out from the patient's family. And that's what makes us unique. That's what palliation is. And have I seen palliation happening in cardiology? Of course. I had a lady and she could not qualify to go for a valve replacement, 82-year-old. I knew the survival was about 6 months again. I was not carrying the crystal ball, never carry a crystal ball, because it's extremely difficult to do the Monday morning quarterbacking when you come back and see the patient still alive. So I always say that. But the fact is that she was not a candidate for, all surgeons refused her to get a valve replacement. We did a valvuloplasty in those years. Now today you can do subcutaneous or transvenous. So you can do percutaneous. So the whole idea is wanting to see how best you can offer that palliation, even in cardiology, neurology, in cardiorespiratory conditions. Patients dying of COPD, bad asthmas and bad respiratory conditions and what have you, constantly. But you can minimize their breathlessness. You can minimize their suffering from pain, their seizures, or whatever else that's going on in their lives. So important. Well, this was this trophy sits on my table now. I admire it every day, and this is after my 25 years of my service there. It's a compatio and says, "Whatsoever you do for one of these, even the least of my brethren, you do unto me." So I admire that. And you see, everybody there is actually bowing towards the patient. And my wife pointed that out so well. She said that, you see, the nurse here, the pastoral holding the hands, and the doctor also, so the body gestures, everything really matters. Your body language matters when you walk into the patient's room. And again, a picture is more than a million words on that trophy, as I define. I come to this very solemn moment where I have to share that my son passed away 2 years ago. Moni was an extraordinary person with a great deal of enthusiasm and ambitions, and contributed a great deal to finance, media, business. Went to the top schools, NYU and Columbia Business School, worked at ABC, CBS, brought in an Emmy trophy sitting in my living room. We constantly pass by and proud on it. It's an extreme grief we are suffering from. His older brother here is in the audience. He's a professor of humanities from Virginia Tech. This pain will always be with us, but he contributed a great deal to me. He brought patient education to the forefront for myself because he knew that Daddy always talked about 40 years of patient education. So he helped me set up one of the most premium cardiology channels, I should say, which is on 3 platforms now: Facebook, YouTube, and on video, on Vimeo. It's called Muni. We named it for him, MuniMeterHealth.com. And now it's been 4 million plus viewer minutes have been recorded, and every single penny of it will be bestowed towards his legacy. Nothing is for our personal gains. We promised to each other, because the way he really created this MuniMeter Health for us. Today, NIH, MGH, they're talking about patient education, and they're putting articles out. And I've been at the, like Dr. Sharad was saying earlier, even in India, I'm humbled to say that I've been honored for the patient education that I have brought to their forefronts as part of the medical curriculums. I think it's so important because you can narrow the gap. All of us, what are we doing? We're doing a CME here. We're educating ourselves. I'm sharing my experiences with you. You're sharing your experiences with me. And we're learning as we go along. However, the patients are still there. We need to narrow that gap. The patient education needs to be enhanced. It's so important. And believe it or not, the clinical outcomes will be outshining. That's very important. And this is the website we have, MuniMeterHealth.com, for our son. This is where we are today with our knowledge. Remember the earlier slides I showed you where there's a whole bunch of people, the humans surrounding that patient and the child and the pediatric wards or in the surgical wards or in the medical wards. Here we're lucky if you find a technician or a nurse inside in that CT/MR. Most of the scanners look like this, the PET scanners. I'm doing more SPECT scanning. As you all know, in the nuclear cardiology, it's all SPECT CT. So very similar scans, but it's very devoid of, obviously, people are concerned whether it's, they're phobic to get into a little tunnel there and all that. In fact, following a back injury about a year and a half ago, I had to go through that MRI. It wasn't very pleasant either, and some of us can relate to that. Nuclear scans, look at that. We're always looking at the blue myriad of screens. I'll be lucky if I have some residents and fellows around me, and I can pass on my pearls to them, I guess, in a way, for them to learn and become nuclear cardiologists in the future. And so everything is now getting a little more non-human, if you will. And you're relying so much into that. But the fact is that if it makes it so easy to actually devour all that information, structurally, metabolically, biochemically, why do we not have actually increased time to go by bedside and meet the patients and family? I asked that question. Maybe perhaps the pendulum has to swing back and we should go there. And that is so important for us. Is artificial intelligence around? It's here. I've been doing it for the past 15 to 20 years. The algorithms, which are iterative, they actually tell you exactly where this patient's territory of blockages are. And we compare A with B and immediately come up with that, because data collection is so much that the iterative, what you call algorithms really speak out, whether it's the left main involvement, the triple vessel involvement, or what have you, et cetera, looking at the non-intervention. So artificial intelligence is already here. Robotic surgery is happening, we know that. I mean, you could be on the West Coast, somebody may be operating on the East Coast, and you have a handful of surgeons out there, and they're looking at just to be available for emergencies. That's about it. But actually, the robotic surgeons could be actually playing it on the screen right here on the East Coast, and be operating on the West Coast. So those things are happening already, as we know. Lots of laser surgeries around the corner. Telemedicine, of course, in the past 2 years, everybody knows telemedicine. Increasingly it's become popular. I'm not a fan of that, because I think nothing like meeting a patient and understanding. But there are groups and there are websites where people are starting to write prescriptions, not knowing what the stuff is, how things are going. So I think I'm a little. This is the father of surgery, Sushruta. And this is at university. Actually, this is the Royal College of Physicians and Surgeons in Melbourne. And I was just there 2 years ago. I mean, 2 months ago, pardon me. And Sushruta, the father of surgery, they have that. And this was in 600 BCE. Tells you that how much involvement we have had in our culture, in our history of medicine. Like I was saying, how all of that has evolved, and still we are coming back to the same level of care. How about alternative medicine? Why are we forgetting that? And there's a resurgence you may have seen on yoga and meditation, relaxation techniques, and what have you. All of that is coming back because people are starting to believe that there is something important in that part. And again, it's the humanity, it's the humane touch that comes in, because that's where we need to focus on. As I said, the future is here. The explosive 3D scanners, perhaps I think I always tell my students sometimes that maybe we'll be walking around giving sign-offs on genetic reengineering here, stem cell thumbprints on this one, and we have not only about the organ transplant, because already actually we have the stem cell thumbprints here. This patient is going for laser therapy, and these may be the sign-offs we'll be probably doing in the next few years, the way it goes. And so it could be a regular work list. I predict that it's going to be a regular work list for all of us very soon, if not later, and it'll be there. So we will, but nothing like still. I hope when I lay in bed one day, which I think we all will do. I mean, this is inevitable. It always happens, to all of us. But I'm saying, if I get sick and I'm laying in bed, I still would like to see the doctor come in white coat and visit me. I personally would see. I'd like to see that doctor from the other end of the bridge, how he or she actually comes and helps me and takes care of my pain. If it's not too late, this is what happens. In order to make an appointment, he first had to update his operating system, download an app, get a username, choose a password, log into a health portal, navigate to a message, and write his doctor. By then it was too late. It's a very touchy cartoon, but I wanted to save that because somehow it speaks a great deal. So folks, let the magic of healing work wonders as we explore the human element in all of us. It's plenty around, not on the periodic table as yet, and we just need to find it, revive it, and like I said, we need to reinvigorate it for the care of the patients. I thank you all for the attention that you've given to me in the past several minutes. Thank you. I'm indeed honored and humbled here at this point. This is the book that came out last year. It's now displayed at the Library of Congress. I proudly say so. And many other regional and town libraries as well. It's catching up. So the message is spreading, as you see. The human element is. So I acknowledge that in a way that, hey, I'm thankful that I put in my 2 hard years, I should say. And Muni did know about this book that I was writing, so he was well informed about that book. So he's blessing me from the top. Well, my grandchild, she turned 13, and she told me, Baba, I think you should put your element on the top of the periodic table. So here it is, guys. So I'm very proud that my grandchild has really offered a great idea. So one day, hopefully, it will be there. If not, just find it there in you. Well, we skipped the season almost, I guess, here also, and we're about to get into the spring and into our summer soon, so hopefully we'll all have great seasons. Just a word about this gentleman. He's out of Cornell, Columbia. He passed away at the age of 92, made compassionate care a cause. Many of you do not know him, perhaps know him. He devoted 50 years of his medical service at Cornell as a pediatric neurologist. Now, an Arnold Gold Foundation, 1988, was established on humanism. His words were, "You're only half a physician if you're just good at your craft." And I stole that line earlier in my talk. A patient-centered humanism makes you a complete physician, Dr. Gold. And he's the one actually who now in every medical school, this foundation has gone in and started to say the Hippocratic Oath should be taken on the early days of the medical schooling. And some of you are nodding, I think you're already aware of it. But Dr. Gold was the person who actually, and the long story short, what happened was he was being presented by a case on a wonderful afternoon. And if you read the story, I'll just make it very short. And the student walked up to him and said, he said, "Hey, what do you have, John?" He said, I have a brain tumor to present from room 209. And he said, "Do you know anything about the family? Do you know how it has impacted the patient's family, the child's family, the child's parents?" The answer was no. At that point, he came home. Dr. Gold returned back, spoke to Mrs. Gold, his wife, and said, "Look, I'm devastated after my 35 years of my practice, and this is what I'm seeing where medicine is going. It's extremely, extremely worrisome." She said, "You do something about it or you better shut up." And guess what? The next day, Dr. Gold started this foundation. He said, "I better bring that humanism back into medicine." And he toiled since 1988 till he passed away in 2018, and he was 92 by then. So for 30 years, this has been a huge endowment. So similarly, again, I cannot match that, but the very fact that we have our Human Element Foundation, where Human Element, like you introduced me earlier, Human Element Medical Corporation, which is our foundation in the name of Muni, obviously, and of course, all proceeds from the books, all proceeds from the lectures that I do nationwide and sometimes internationally as well, automatically go for his legacy. Not a single penny will be ever shared for our personal gains, and I can assure and promise that. And this is his website. This is the link, if I may, airdrop to you, all of you, if you have your iPhone open for a second. And I'm not very, very savvy on this, but if you have your link, here we go. If you're on airdrop with me, I will do that now for you guys. And you'll have the link where you have does the airdrop working? Yes, it does. Oh, here it's showing up. I'll wait till many or as many can come in. And beautiful. I'll give it a few seconds. So that will be the link where you can actually procure the text, the book I showed you, the Human Element book, for $25 instead of $35 that Amazon is charging. But Amazon, it has already hit the list of bestsellers, and here I'm doing it now. Some of you already got it, I guess. The link, you can accept it. And if you go on that link, you'll be able to order the book. But I do have some books here in person that I'll be willing to sign in person if you like, and if you like to procure a copy of that. So I thank you one more time for your extreme, interest in my little speech here. Forgive me if it was a little too long.
Thank you, Dr. Jaitly. I'm sure many would be willing to stay after and talk to him if you can entertain some time. And thank you very much.
Absolutely. Are there any questions, comments that anybody wants to ask? I know it's a little extra over the time, but I greatly appreciate your time.
We'll have them come up after.
Okay, absolutely. I know you have to make your rounds and you have to get on to the minutes. I thank you again.